Okay, good afternoon everyone and welcome to this afternoon's session and the Marketplace of Innovation. I hope you've been having a terrific day so far and getting to appreciate probably some of the new drivers and the emerging trends in the broader health sector that are likely to be playing out for us, and certainly started that thinking about our model of care framework and perhaps being stronger in the spaces around integrated, multidisciplinary, person-centred and values-based frameworks. I think what I took from this morning was that we are going to be working in new ways. So isn't it terrific that this afternoon we are going to hear from people who are showing leadership in that space. I will say that we have 100 minutes at our disposal today, of which, and we have 100 minutes of presentation, so already I'm eating into that possibility. So we're going to be pretty strict and on people moving through, and there won't be an opportunity for questions at the end of each presentation. However, as the last slide, we'll have the contact details for everyone who's presenting, and I'd encourage you to follow up with them after the session and ask plenty of questions. They've said to me they're very, very keen to be hearing from everyone. That's what you said to me, wasn't it? And as many questions as possible. So on that note, and for the presenters, we'll be showing the 2 minutes to go sign on the white bat. Everyone else, just don't laugh, just sit there and take it. And then to avoid us having to have that stage hook, we'd like you to be ready to wrap at that point and come to a conclusion. So without further ado, I would like to welcome our first speaker, Keegan. And Keegan is talking to us about medical mapping, and he is from Peninsula Health, and I'd like you to give him just another warm welcome because I messed up in front of him.
Thank you, Louise. We are here today to shape tomorrow. Understanding our clients' journey to care is essential to us improving health outcomes. Unfortunately, our clients encounter many challenges in seeking healthcare more broadly. These challenges include geographical and social isolation, limited referral pathways between providers, and low levels of health literacy, where the Australian Bureau of Statistics suggests 60% of the population have difficulty interpreting health information. All of these contribute to poorer health outcomes. Eligibility and priority group status is something that all of us have difficulty defining. Let's then take a moment to think about our clients and our referrers. I challenge you to write one sentence in easy English that defines both. If only it was simple. Is your name Primrose, Brindabella, Tulip, Lotus or Pansy? For those of you that are confused, yes, I am talking about the hippos at Werribee Open Range Zoo. And if you haven't heard, yes, they too are now a priority group. Good afternoon, ladies and gentlemen. My name is Keegan Crowe. I'm a hygienist, therapist and team leader with Peninsula Health. I'm here today to walk you through the future of referral relationships between primary care providers and oral health care services, both public and private. More specifically, the development of an oral health pathway that sits within Map of Medicine. I will preface the next part of my presentation by saying that I will refer to a GP, but I do mean that it encompasses all primary care providers. What we'll be covering off today: understanding the client's journey to care and what was the missing link, the strength and value of partnerships, and the oral health pathway itself, what it looks like, and how we can best utilise these tools going forward. As we all know, our clients experience a greater burden of disease, poorer general health, and therefore poorer health outcomes. If we look at GP attendance statistics nationally, per capita, we are almost 4 times more likely to visit a GP compared to a dental practitioner. For our clients, GP attendance rates treble the national average. We are not going to unpick the reasons why many of our clients see a GP in the first instance for oral health concerns. The important thing to remember is they are seeking help. The oral health pathway is therefore the critical link. The pathway will ensure timely and appropriate referral of clients presenting to their GP with dental concerns the first time. We have been fortunate to have a team of like-minded professionals around the table and at arm's reach. They've contributed time, resources and the expertise to develop the oral health pathway, which went live in November of last year. I'd like to acknowledge the contributions of the South Eastern Melbourne Primary Health Network, the Peninsula Health Promotion Team, and our review partners in general practitioners and dental practitioners. Your contributions have been significant, and this would not be at all possible without you. So the oral health pathway itself. The pathway is the first of its kind nationally, and as I stated earlier, currently sits within the Map of Medicine online platform. It is an online tool, a decision tree, if you like, aimed at primary care providers, with 2 key objectives: to provide access to best practice oral health resources and to facilitate the timely and appropriate referral to oral health care providers at the point of care. The pathway does contain links to key services, resources, and to the Peninsula Health Dental e-referral tool. Through providing links to other key websites and resources, we are able to ensure that the information aligns with current best practice guidelines, which, as you all are aware, do change at most times annually. And also ensure that accurate referral information is also available at the point of care. Examples of the resources include the therapeutic guidelines, where through the use of antibiotic and oral and dental guidelines, we've had an opportunity to get in the face of GPs and present to them what the dental profession looks at in terms of what is appropriate for a client presenting with toothache or pain or infection, and whether antibiotics are appropriate. So it's a way of us improving our referral relationships, but also tackling antimicrobial stewardship all at the same time. It also includes links to DHSV and the oral health resources that they do provide, the Department of Health and Human Services in regards to eligibility criteria, the Peninsula Health Dental e-referral, where electronic referrals can be submitted for all client groups, acute care services, so we're talking hospitals and specialist areas, and also the National Health Services Directory, where there's links to private providers. So it provides information to the GP and to the client at the point of care. And this next slide gives you a bit of a snapshot of what that actually looks like in terms of functionality. Unfortunately, I don't have enough time here today to take you through a live demonstration, but this slide briefly outlines how the GPs and other primary care providers can use the tool to gain information and also provide referrals both to public and private providers. I would certainly encourage you all to log in to Map of Medicine. I have provided the web link at the end of the presentation, but I'd encourage you all to have a look. The future. I'm confident that the oral health pathway will be one of many advancements for the sector as we try to embed referral pathways within the primary care space and across our networks. The oral health pathway as it stands is only localised for the Frankston-Mornington Peninsula catchment, and our vision is for the expansion of this pathway statewide. To achieve this, as there are multiple online platforms used for referral pathways more broadly, we may need to look beyond map of medicine to facilitate that. As I said earlier, I would encourage you all to take the oral health pathway back to your organisation and to your networks. You can actually print off the information and print off the whole pathway, which provides you all the links and the information. So we would be more than happy for people to replicate it for their local areas. And together, we can strengthen the referral pathways and improve health outcomes for our clients. Thank you.
Thank you very much, Keegan. Now I'd like to welcome Marietta, who's beautifully in position. And Marietta is from Bendigo Health, and she is introducing us to the peer support program. Thank you.
Back in my day, this thing made me the coolest kid in grade 3. And back in my day, they kicked us out of dental school with a degree, and we went off straight seeing patients. And as a new graduate dentist, I was miserable. I was absolutely miserable. I was stressed to the eyeballs. I felt like all my patients were ever going to do was complain about me. I was constantly worried and afraid. I tried to get out of dentistry. I was unsuccessful in a PhD application. I went part-time, all of these sorts of things. I was in the Navy at the time, and eventually I quit the Navy and went into part-time private practice. And that's when I met Nigel, who was the owner of the practice, and he was my first mentor. Now, I had worked with other dentists, other experienced dentists before, but I think this was the first person that took me under his wing in a way to help me develop as a dentist and to become better at what I do. He was a great dentist and he had a great work-life balance. He loved his family, he loved to fish, and occasionally he wouldn't show up to work and we would find out that he was being rescued by the Coast Guard. And he loved to eat. We had a hatted restaurant right next door to the practice, which he would frequently lunch at. So how was this relationship different from the other experienced dentists that I'd worked with in the past? And I think in 3 ways. One, he was a great clinical dentist. He had these skills that were amazing, and I aspired to be like him. 2, he thought I was a good dentist. It was reciprocated. He felt I was valuable and that I was worth an investment. And 3, importantly for me, with my anxieties, I felt he had my back and he supported me through tough patients and tough events. So at Bendigo Health, we're a 31-chair clinic, and I will often have 5 or 6 new graduate dentists and maybe 4 or 5 new graduate oral health therapists. And we have a strong focus on peer support or mentoring. And for a couple of reasons. One, as it's reflected in my life, it really improves job satisfaction. 2, it improves the quality of dental care and patient safety. And also for me as a lead clinician, it's an active element of performance management, which is now a requirement for credentialing, if you'll notice on the documents. So the functions of peer support, and you can get this from the literature, they're educational, supportive and administrative. And so when we come back to, again, why do we provide peer support at Bendigo Health? Because it improves job satisfaction. Dentistry is incredibly stressful. It can be a very isolating profession, just working alone in a room with your dental nurse. And there's an incredibly steep learning curve. You know, someone comes out of medical school, they're an intern, and they're barely allowed to make a decision on their own. They are under training and supervision for years before they're responsible for independent patient care. We pop our dentists out straight away, ready to undertake those tasks. It also improves the quality and safety of dental care. It really aids my role in providing clinical governance. It promotes a supportive culture, and hopefully I'm able to catch issues and small problems before they arise, and creating a supportive culture rather than a punitive one where we're just punishing people or jumping on top of them when something goes wrong. And that also assists performance management. So where do we start at Bendigo Health? It's hard to see, but I have a very comprehensive document that you can see that I lay out in really clear language what I expect from my new clinician. Things like, I expect you to arrive at 8:15, I expect you to leave at 4:45, I expect you to engage in 7 hours of clinical practice, I expect you to have good communication skills with your dental assistant, I expect you to be a team participant. I don't leave it to common sense, I really try and spell it out so that they know what it is that I'm after. And we start with a peer support agreement. This comes from an allied health background. You'll find that speech pathologists and physiotherapists and OTs all have these sorts of documents and use them regularly. Peer support or clinical supervision is an active part of what they do. So when I start with a new clinician, I go through all of the things that I might assess and that I might review. We have a discussion about how they'd like me to bring up tough topics. I usually start with, look, what if I get a written complaint about you? How would you like me to broach it with you? The other thing that I do, I tend to talk too much and I tend to be a bit brash and can take over. So I warn them that they are the things that I do, and that if I offend them in any way, doing that with a patient, that I want them to let me know. So I kind of try and warn them about my flaws as well as a mentor. We sign these things and then we agree to meet about once every 6 weeks. We discuss what we'll cover, how they'd like me to broach difficult topics, and how often we'll meet. We meet one-on-one around about every 6 weeks or so. We have a peer support meeting in the morning. We then have a monthly mentor meeting, which is a group session where all of the clinicians come together and we cover various topics. We might have external speakers, one of the clinicians might broach a topic, or I'll broach a topic. And then there's all day, every day, constant access. I carry my mobile phone around, so even on my non-clinical days, I come running if it's a difficult patient or if they need help pulling out a tooth or they'd like me to review an OPG. And quite often they know the right answer. It's just a little bit of support to confirm, yes, you're on the right track. There's also a bunch of other things that I audit which are more part of the performance management and the clinical governance. I will complete a dental record keeping audit on their behalf. I'm reviewing their records to make sure I'm happy with their record keeping. I look at their clinical indicator reports and I expect them to provide me with a written lessons learned from the indicators that come up. I look at their service mix, I look at their obturation radiographs, I look at their fixed pros, I review their specialist referrals, all of these sorts of things. It's much more intense at the beginning of their term with us. It's much more free and less invasive the more I know them and the more I am comfortable with their experience. And administratively, I guide them towards a DWAR target, a productivity target. We look at error reports, written treatment plans, and to making sure they're completing their mandatory training. And of course, non-clinical aspects. There are bucket loads of resources for peer support or clinical supervision available on the website. And this New South Wales Super Guide, a guide for supervising oral health professionals, is terrific. So it's what I would recommend to any experienced dentist who might be mentoring someone else. Thank you very much.
Thank you very much, Marietta. I know I shouldn't say anything, but I'm actually in the process of working on a peer support and mentoring program, so, I'll be catching up after the break. I'd like to now welcome Diane and Nicole, who are from Dental Health Services Victoria, and talking to us about the particular teledentistry project. Thanks.
Thank you. I'm sorry some of you may have heard this before, but I'll be as quick as I can and just cover some of the topic. Oh goodness, I've gone the wrong way. That's a good start. So what is telehealth? Telehealth is the provision of dental care. It can be advice, it can be guided treatment, it can be making referrals, it's education, it can be public awareness. And it's through the medium of technology and telecommunication rather than face-to-face, really. There are 4 ways you can use telehealth. One is the live video. So in our project, it was live. The patient, the dentist, was on the other side of the screen and our specialists were on this side. You can have store and forward. So that would be if a dentist or an OHT went to a nursing home, they could have the intraoral camera, they could take away 3 or 4 videos that they might want the dentist to look at when they get back to the clinic. Remote patient monitoring, that's not as important for us in dental, but that's where someone can dial in to the patient's home, they can look at their blood pressure, they can look at their sugars, they can monitor the patient's from their home. It can go straight to the GP. GP can get it daily and have a look. And the last one is mobile health. So that's when you take, like your dialysis machine, and you take it and someone has it in their home and it will feed back the results to the clinician. So the purpose of teledentistry when we started the project, and I'll talk about the project in a minute, was to provide innovative specialist advice and advanced dental care to patients in rural and remote regions. And while I said what it was when we started, what the project has shown us, it can be also used in suburban. So it can be used across all our areas for the dentist and the specialist to communicate. It's not just for rural and remote. It provides a platform for integrated dental care. The great thing that we found as we went through telehealth was the patient, the dentist and the specialist all planned the treatment all together. So it's not this jigsaw puzzle where the community dentist refers to RDHM, the referral stays here, it's then screened, it's then put on a waiting list, then the patient comes to see us, and then the specialist says, oh, maybe you don't need PROS, maybe you need endo, and then the patient goes to endo, and that could take 2 years. It actually allows 3 people in a room, or they're not all in the same room, but they're all together to plan together. So we did a pilot. So in 2015, we got $320,000 from DHSV. That was just for equipment. So DHSV actually sponsored me at the time when I was the project worker. We started in June in 2016 with Goulburn Valley Health, and then we went to 3 more agencies: the Trobe Community Health, Peninsula Health, and Southwest Dental Services. We chose those agencies for many different reasons. We chose Goulburn Valley because they'd had experience at Telehealth, so it meant for the first site we had someone who could work with us. We chose other agencies because they didn't have as experienced dentists, so we wanted to see what would happen using Telehealth with someone who didn't have a lot of experience. We also chose them because someone had done the dentist with special skills training, so we wanted to see what those variations would bring to Telehealth. During the pilot project, we had 17 sessions and we saw 62 patients. Since then, we've had 30 more sessions and 30 more patients, we've had 9 more sessions. The interesting thing since the pilot is that all the sites have continued to use telehealth and book in. During that time, we did supervised treatment, so the dentist was on the other end and the specialist was supervising the treatment as it occurred. We provided advice. The best part of it, I think, was the additional cases that were discussed. So one of the great things that came out of telehealth was the mentoring. The dentists in the community really valued to be able to talk with the specialist problems they had during the week. And what it also allowed is that the specialist could tailor their advice to the dentist's experience. And that was probably the best thing, because you've got someone like, say, David Whelan, Goulburn Valley, who had a lot of experience, who was talking to the orthodontist. That was at a quite different level to the oral surgeon talking to a dentist who was first year out. And there was just great ability for that to be shifted and moved to what the person on the other end of the video needed. So in a way also they personally got to know the dentist. So since then, a lot of the dentists in telehealth will ring someone like Hanley in oral surgery and say, I've got this, what do you think I should do? And that sometimes means that there is no referral, that the patient in the chair can be seen and the treatment can be completed, and they never had to go through the referral, the screening, the waiting list. So it's actually brought people together. Oh, sorry, I've just turned it off. So the specialties we saw were oral medicine, oral surgery to begin with, and we thought they would be the best specialties to see. In fact, the community clinics asked for other specialists, so we had endodontic sessions, orthodontic sessions and special needs. So we thought it would have limited ability to apply it. It actually was successfully applied across the board. And we were really surprised at what specialties this worked with. I mean, endodontics I never thought, but it worked really well. So I'm going to hand over to Nicole, who's actually going to talk about the clinical case.
Which button?
It's that button.
That one. Okay. So initially I had concerns, but I can understand why oral medicine was one of the specialties that was chosen initially, because we're more sort of consultative, we do a lot of counselling, it's a lot of talking, and we could guide the examination with the dentist on the other end. I was concerned about developing that rapport that we need with the patient, about how good a history that I'd be able to get, and that's really important. And, you know, because when we do get a bit touchy-feely in oral medicine, and I don't just mean emotionally, you know, we do have to sort of palpate and look closely. And so part pain, we'll give you an example of both pain and mucosal here. So this was our first patient, and clearly she was a high-risk patient. So we counsel patients with lichen planus as it being a potentially malignant condition. And here we had a patient who was high risk because she was a smoker and she had a lesion in a high risk area. So a new biopsy was indicated. Country folk, for some reason, don't want to travel to the city, so they loved teledentistry, and I can understand they just don't want to come to the big smoke, it's too difficult, and so that's why they take up the offer of the teledentistry. There happened to be an experienced clinician at Goulburn Valley on the day that this lady was here, and he did a biopsy for us on the floor of the mouth, and you can see that we've got a diagnosis there that I wasn't entirely happy with in terms of it being not completely diagnostic, and so in the end we did have to encourage this lady to come down to Melbourne. We did see her eventually, and I examined her, and I was happy that there wasn't anything sinister remaining, that it was consistent with lichen planus, and so as it turns out, I've now organised with her, and I've yet to organise with David, that we'll say, please you come and see us once a year and we'll get them to see you alternate 6 months at Goulburn Valley, and everything's under control. With this lady, for her pain condition, she had this left facial swelling, and we're like, well, you know, she had a history that was consistent with TMD. It doesn't usually present with swelling, and what I was able to do is organise an MRI for her in Goulburn Valley so that I could send that referral through after doing the history and examination, send that referral through, and she could get her MRI done and then bring that down to us, and then we have a diagnosis that's ruled out anything sinister in terms of, we didn't know if it was an infection or salivary gland or muscular or whatever. And because general dentists, much like general dentists can't refer for cone beam CTs anymore, general practitioners can't refer for MRIs, and so that was something where we were able to save a visit once again. With this patient didn't have to travel to Melbourne, so the oral surgeon, our oral surgeon Hanley, actually guided Yuzu in Portland through this situation where there was a gingival swelling that it wasn't bony hard, it was firm, it was fibrotic, it wasn't fluctuant, and no draining sinus. And so the dentist is thinking, well, you know, what is causing this? And this is something where you'd have to rule out neoplasia. And the biopsy was concerned, and as it turns out, the oral surgeon guided Yuzu with the scalpel and the incision, and pus came out, and so it turns out that it wasn't anything more sinister than a non-vital tooth. It just was an atypical presentation, and so that patient got sorted out without having to come to Melbourne at all and not being on a waiting list. So this is what we've learnt. We've learnt that it works. And so The patients, I think that, as Di mentioned, the greatest thing was the communication that we had with the dentist in the clinic and then being able to ask questions. And we would have little side consultations about different cases and different radiographs and everything. So there you go.
And just to mention that we are going to roll this out across Victoria, so there will be a way forward. We're just looking at how we do it, and the equipment will be rolled out very soon. So just contact us if you want any more information.
And you always call us if
Yes.
there's ever anything urgent.
I've got the microphone, so I'm just going to be pushy. Thanks very much, team. And thank you for giving us an opportunity to try out the bat. It's working. So, and thank you very much for picking up my bits and pieces of paper, Nikki.
It's upsetting me.
Oh, okay, thank you. Okay, we'd like to now welcome Nikki. Nikki's from the Health Issues Centre, and in keeping, I think, with a lot of the discussion this morning, is talking to us about patient-centred care. Thank you, Nikki.
Thank you very much. I apologise that I wasn't able to get to this morning's session, so I hope that I'm not going to say anything that's too repetitive to you. I am from an organisation named Health Issues Centre. We are funded by the Department of Health and Human Services, Victoria, and our space of work is very much in the area of community engagement and consumer participation in health. So you're going to hear something and experience a very brief presentation that's quite different to the ones that have come before and possibly afterwards. Bear with me. Put your hand up if you're a consumer that's here today. How are we dealing with all the jargon, folks? What the hell's a TDM? Okay, let's think about that for a minute. You know, we're peers in this too, yeah? And so if we want to practice being patient-centred, we need to start from the beginning with a language that is common to all of us as much as possible. I know that's tricky when we're talking about clinical stuff, and I don't say that at all to be disrespectful to the presenters who've come before me, but let's think about that as a great place to start. So if I took a stroll with you now out onto Spencer Street and I said the word engagement to people, what does that mean to you when I say to you engagement? What do you think people might say back to me? There he is. I know none of you have ever watched this dreadful show, of course, have you? I've only watched it, obviously, for the purposes of my intensive research into my presentation today. But have a look at him, right? What a guy. Why is this ridiculous? Why is this ridiculous? A few things. What's gone on before he's been the bachelor, right? A bunch of people, experts, have sat back in an office somewhere and decided what, you know, a woman's, because we can only deal with mainstream relationships, right? A woman's ideal bloke is, right? Actually, there's probably a lot of blokes' ideal blokes too, right? Like, really. But have a look at him. So here they have, they've created this fabulous person that everybody's gonna want, right? And then there he is. And what's he doing? All of that's gone on behind the scenes. Then we've just introduced some consumers into the situation, right? Who all look like Barbie, yeah? And because that's how all women look, right? All the time, girls. That's what we want. And what does he say? What does he say to people? Come on, don't have shame. Don't make me say it. Okay, I will. I have no shame. Will you accept this rose, right? Ugh, no. But let's think about the way that we practice trying to get people connected to our services at the moment. Is it like that? Are we the people who sit back in our offices, in our little teams, in our groups, with our heads all together and work out what's the best way to engage with consumers and the community? Or do we actually have that discussion with them first and actually ground what we're doing in what actually works for people? Because for anybody who reads the Woman's Day or whatever it is the week after this last one's screened, right, we know what's happened, don't we? They've broken up already, right? It hasn't worked out. Oh. So, let's think about what we're actually talking to you about when we're talking to you about the notion of engagement. And this is what we're talking to you about. We're not just talking to you about how you tell people stuff, right? Or how you communicate nicely with them when they come in to your service to see you, right? This is what we are talking about. We are talking about a point of connection, about a partnership that we are bringing people into with us so that we can deliver better care, whether it is at an individual level of care or whether it is more broadly looking across our community at the people that are going to come and see us. And also the people who aren't coming to see us, because when people aren't coming to see us, we need to know why, yeah? So we can try and work on those things and find solutions where we can internally, and also advocate. Where there's so much advocacy needed in dentistry. We know how poorly funded public dentistry is. We know what happens to people who don't receive dental care. Yeah, their health and their well-being is severely compromised. We have standards in Australia for dentistry, of course, as we do in mainstream medicine, that very clearly articulate to us now the place of person-centred care, patient-centred care, whichever acronym we want to use, and its relationship to quality and safety of care. But I would like to say to you, and I know that there are many people in the room who are probably quite familiar with these. If you're not, they're available online. You can quickly search them out and find them, or we can send them to you. These standards, when you're reading these standards, when you're accredited, whatever else, and you're meeting these standards, fantastic. That's not where it stops, folks. This is a minimum, right? If we really want to go where we need to go with this, we need to, within our organisation or within our practice, take these as a platform and develop standards for ourselves that exceed them. And actually develop those standards in consultation with the people who are using our service. That's partnership, that's engagement, that's working towards achieving for everybody as much as possible the care and the outcome that they need. We constantly need to remind ourselves of this. I have this on my desk, which is kind of amusing. Think about it. But it actually is. This is what this is all about. If all of the decisions that we make in the planning, the design, the delivery and the valuation of our service are made by us sitting behind a desk, we are missing out on so much. This is a partnership. What we need to be doing constantly is applying the Lara Bingle principle to everything we do in terms of our practice. Where the bloody hell are they, right? Nothing about them without them. Talk with your consumers, talk with your community when you're doing all of those things within your practice. Everything that we talk about when we go out and talk to health services and to clinicians about working with consumers is centred on the idea of this, the social determinants of health. I could happily speak to you all about this for like, 10 days. You'd love it. But just very quickly, what this idea of all about is, it's a reminder to us that not everything about a person's presentation is to do with their physiology, yeah, or their clinical details. In fact, sometimes very little of it is at all. If we think about these things, there are many different representations of the social determinants of health, but we think about some of the things that we know marginalise people from being able to have good health, whether it's dental health or more general physical health. We also know that there are barriers to people actually coming into services, even when they really need to, and even when we've thought we've done everything we can to make ourselves open and welcoming and inviting and all of those things. So let's think about this, but then let's bounce another idea off this, thank you, and ask ourselves this question. Are these also the social determinants of engagement? Because I would argue with you very strongly that they often are. And if we think about the constructs that exist at the moment for us receiving advice from consumers, feedback from consumers, whatever tools we are using at the moment to check in about how our service is going, there are people missing from those conversations all the time, right? And often they're the people who are most marginalised from accessing us. So it's really important that we continue to ask ourselves these questions and that we understand that people's health happens out there, yeah? Doesn't happen within the walls of our organisation, so that's not the place to have the conversations with people. The place to have the conversation with people is out there in the space that they're in, that they feel comfortable in, and where you'll have the best chance of getting good communication from them. I'm sorry, I'm going to kick a few slides. I want to get to this because it's Friday afternoon and you need a chuckle, right? But it's really important that we think about this. It's deep, right? It's really important that we create a learning environment for ourselves. Every patient that comes into our service is a learning opportunity for our clinical staff, for our support staff, for everybody that's coming into us. So it's really important that we find ways to develop relationships with people and understanding of people that goes beyond learning about them like this, from facts and figures and numbers and all those sorts of things. And that we actually ground our practice in this, the two ways of knowing. This is about creating a partnership. Our consumers, our patients, whatever we'd like to call them, have ways of knowing and ways of telling you things that might be quite different to the way that you've been trained or the way that you've been encouraged to practice. It doesn't mean that they don't have an equal amount to contribute. So whatever you do, I encourage you very much to please think about that. I could talk to you about this all day. I've got the second paddle. So what I'm going to say to you is if you're looking for ideas and information about this, please contact us. We'd be very happy to talk to you. Thank you very much.
Okay, so what's joined my lexicon as Nikki leaves is nothing about them without them. We all write that down. I think it's a really good message. Thanks, Nikki. And now we're joined by Anita from Trobe Community Health, and Anita is going to chat with us about promoting regional employment opportunities. Thank you.
Thank you. Okay. So across Australia, there's a shortage of dentists in regional, rural and remote areas. That's nothing new. This is contributed to by the perceived lack of enticements and opportunity for growth in these areas. You hear all too often that working in rural and remote areas just means you'll be doing extractions. LCHS has had final year DDS and BOH students doing clinical placement for over 12 years. The students do a 5-week placement at our Moe and Morwell sites, and this gives us a small opportunity to promote the need and benefits of regional employment in the public sector and to draw them in, especially before they find out the pay rate. To do this, we place emphasis on the benefits of working in a large team, and we promote the Gippsland area itself. From day one, we make sure the students feel part of our team. The students form great relationships with the staff at LCHS, and in that short time, these relationships continue. The dental staff show support and commitment to the student journey by also attending the graduate ball at the end of the year. We invite them to social outings after hours while they are staying in Latrobe Valley, and this includes things like going out for dinner or going bowling or lots of other things that they can do in the Gippsland area. This gives them a taste of the social activities they could do if they even moved to the Gippsland area. We discuss our hobbies with them and the activities Gippsland has to offer, such as skiing or snowboarding in winter, the great beaches and lakes for water sports, the abundance of trails for cycling, walking and hiking, and one of my favourites, four-wheel driving. And I'd just like to point out that cute little blue heeler puppy is mine, and I had to find a way to get him in there. Several of the students that choose to relocate to the Gippsland area to accept jobs with LCHS have been able to rent a room with staff during their transitional period, and in some cases this has become ongoing accommodation. For those that choose to live in Melbourne and commute, we offer flexible start and finish times that align with the train timetable. During the student placements, we get the opportunity to show them that we are about more than just clinical. We provide a learning environment that extends past their first year of employment. Staff has access to CPD sessions in the area. We have internal professional collaboration sessions with the rest of the organisation, and staff also attend clinical meetings where they're able to discuss clinical cases and learn from their peers. Gippsland is an area of high needs. A lot of the patients have complex medical histories, and there's a high caries rate, and we have a large population of special needs patients. So the variety of treatment the students get to see is a big draw card for them. They get to manage a range of complex cases during their placement, giving them a realistic expectation of what it would be like working for LCHS. A past student recently told us that working at the Moe Clinic was the first time that they felt they were able to utilise their full scope. The diversity of staff that comes with a large team also means that mentoring can continue to be provided during their years working at LCHS. This being said, we always ensure that we have the right amount of senior staff to support the graduates being employed. Currently, we have 2 dentists and 2 oral health therapists that were recruited after doing student placements with us. 1 has now entered their 3rd year of employment with us, and 3 are now in their 2nd year. These valued staff members said they chose to work in regional Victoria because I'm able to help provide accessible care to those with high needs. I receive mentorship from senior staff. I receive the support required in order to gain confidence and develop skills. Since starting here, I've had excellent support from my managers and mentors in the way of help and clinical advice. The experiences I have gained here as a student and now a member of the team have been invaluable. It's a good mix living in Gippsland, busy at work, but when you get out, it's quiet. And finally, I really like the people I work with. LCHS is now working to expand employment opportunities in the Gippsland area with the development of our regional PROS lab. This is going to be based in Churchill. The vision for the lab is to support local and to service the Gippsland area in both the public and private dental setting. This will not only create many new job opportunities for dental technicians, prosthetists and apprentices, but will create opportunities to network with universities and provide local training facilities in the Gippsland area. This in turn will help create a skilled workforce for sustainable growth in the Gippsland. So in summary, we promote regional employment opportunities to the students during their placement by booking them a variety of different cases so they get a sound understanding of what working in regional areas would be like. We promote the wonderful area that Gippsland is and the varying activities and hobbies that they can partake in. And finally, we make them feel welcome and part of a supportive team that it is about learning, growing and becoming the best that they can be. And if anything else from this presentation, I hope that it's motivated you to at least book a holiday in Gippsland and check out some of these lovely places yourself. Thank you.
Before we just move on, I have been advised that with some changes and people's availability in the program, we'll have some time at the end of the presentations for questions. So if you've got that burning thing that you felt it was unfair, you couldn't ask at the time, feel free to write that question down now, and we'll be asking for your participation and questions at the end. Okay, so on that note, I would like to welcome Jackie and Jodie, who are going to talk to us. They're from Ballarat Health, and they're here to talk to us about developing a great learning environment for clinicians.
We're not going to take Gemma's speech, though, and talk about merging to oral health services.
Oh, sorry.
Although I have heard it, and I reckon I could probably ad-lib Gemma.
Sorry.
So do you want to do Gemma first?
No, that's okay, thank you. So you're going to talk about...
No,
yes, is your presentation...
Can you flick it on?
It's not letting me.
It's not letting her flick it on.
I'll just ask for some technical help, please. That's because today someone said all the technology was going beautifully. So it's, and I've said there's spare time. So it seems only now that we would have difficulty. Just chat quietly, prepare your questions as I mosey my way down to the back of the room, and I'll be back with you shortly.
Yep, that's it.
Oh, yeah.
Thanks.
Go back one, please. I don't think she said what it was. Okay, so we're here today to talk about, we were asked to talk about developing a great learning environment for clinicians and students and the way that we've done at Ballarat Health Services. Just to talk a little bit about our team to start with. We have dentists, dental assistants with Certificate 3s and 4s, dental therapists. We have a pretty big reception team. We have Indigenous trainees, or actually now dental assistants. We have Pathways girls, part of us, which are Year 12 girls doing Certificate 3 in Allied Health that come from local schools. We do work experience students from the local schools, overseas students. We've had a recent one from Iran. We have a CSSD department, and we have clinical teachers, and we have low Trobe specialists, as well as the students that come in. With such a large team, we wanted every person to feel part of the bigger team and that their role is important to us. One of the things that we base our model on is how we actually look after our own employees when they first come to us. So a bit of a personal story. I got a job once and was really, really excited and happy to land this job, and I was so excited, got there the next day and I had to stand in line with the patients, and I get there and the girl at reception said, "Oh, I didn't know who you were." So that was a bit embarrassing. I lost a little bit of my excitement. That's fine. She took me round to the back and I met the manager, and the manager was really, really busy and sort of tried to palm me off to somebody else. So my excitement sort of went down a little bit more. But I thought, that's fine. On the interview, this sounds like a great place to work. That'll be fine. So she palms me off to another employee who had no idea that she'd be looking after me that day. She was not organised, and she seemed a little bit annoyed that that had happened to her. So once again, my enthusiasm got chipped away a little bit more. I didn't know where to put my bag or my coat. I wasn't introduced to staff, and she needed to get rid of me, so gave me a menial task like putting bibs on trays or something. It was really embarrassing and it was really lonely, and my excitement by the end of the day had gone about the job, and I was sort of glad the day was over. Sorry. So from this personal experience, I always thought that if I was ever a manager, I would want to change that and do things really, really differently. You can set the stage by making people a star employee or a star student by changing and doing things a little bit differently. There's some of my beautiful team. So one of the things is that before anybody starts with us, we would contact them, and we would contact them by email. So with our students, they're contacted by email. I have a coordinator that does that, says a little bit about us, what time they start. With our employees, we'd tell them, I'd ring them and I would say, you know, that I will be there out the front waiting for you. I'm so excited that you're coming. I can't wait for you to come. And they know that we're looking forward to them. The other thing I do is I clear my book for the day. I think that if the manager is there and they are showing, or the management team are showing that they're interested in the new employee or the students, that they understand it's from the top. It's not just the person they've palmed them off. So to me, this is a very important change. When they arrive, I tell them, especially the students that come in, that I was excited, that I was looking forward to them coming, and we introduce them to our clinical team and the DAs that day. We sit around and we share some stories. We just don't talk about dental. We'll have a little bit of an introduction to each other, and we share some personal stories. And from that, you know, some of the students might say things like, oh, you know, I'm interested in sports, or I'm interested in this, or I love eating. We tell them, you know, what hairdressers, you know, they can get into, what, you know, sports we can link them up to. We make sure that we link them up to those things, things to do in Ballarat, and, you know, great places to eat, because we love going out for tea. When they get there, their welcome packs are ready. Everybody has a named welcome pack. Their tags are ready, their swipe tags, and their lockers are ready. They've got somewhere to put a handbag and that. Everything with their name on it tells that person, and we do this for our employees as well, that you are ready for them. It isn't done at the last minute. We have been waiting for you to come, and we're excited that you're coming. So look, everything's ready to go, and they know that you're wanting them to start. We also definitely organise a shared morning tea and a lunch, and if we have already some students there, we try to let them come.
One of the other things that we do when we have the students come is, apart from the fact that we introduce it ourselves to them and we introduce them to the team and how the team can support them, is that we actually take each of their photo, much to some of their disgust when they don't know that we're going to do this.
Some of our students in the audience, that's our wall of fame.
The reason we do this is for a number of reasons. One, so that we can get to know people and it's a bit of a laugh when we're doing this with them, but it's also so that we can use this on a day-to-day basis. It starts to build a relationship when we can walk into the room the next day, and I can tell you I cannot remember 25 names when I sit down at orientation. So the next day I can walk around the next morning and say, "Hi Sam, how are you doing today? It was really nice to hear that you're learning to swim yesterday. Did you get on to finding out where the YMCA is," or whatever it is that we need to talk about. It personalises their experience. It helps our clinical teachers that are rotating all of the time being able to walk into a room and be able to use their name so that they believe that they've got a relationship to start with. The other thing that we do is that we introduce them to the DAs. We spend time with them at orientation, introducing them into the rooms, showing them where everything is, so that they're not actually the very first time that they're seeing a patient, especially our fourth year students who are incredibly overwhelmed by the situation. They're not trying to figure out how to use the equipment because it's all different in every clinic, or where everything might be kept, or what their DA names are and they might be. And the other thing we do is we have more time in our model with our teachers. We have more clinical teachers and more dental assistants working with our students so that they're teaching us how to be part of the team.
And in part of that, we do offer our students at Ballarat 3 teachers on every single day and 5 dental assistants, plus tutoring as well.
It's really important to us that our students realise that they are part of the Ballarat Health Services team when they're with us. So they are treated the same as all of our staff members, and they're told about our values and how we integrate that into each and every day and how we deal with patients. They have exactly the same rooms and everything is set up the same way as it is in our public clinic. They're using the same nurses that we use through our public clinic as well. Students start with their own patients and they have examinations to start with. This is really important for teaching, that they're not carrying on from somebody else's teaching plan and their treatment plan, and that they can actually build that rapport with a patient, create those meaningful relationships, but also that they can value at the end of their treatment what went right, what went wrong, and how they could have done better, and they're able to measure that. It's really important to us that the students know that we value them, like Jackie was saying. So every morning as a management team, we go round, we speak to everybody, we speak to our staff, but we also speak to our students as though they are part of our team, because they are. They're working with our patients, they're working for outcomes for Ballarat Health Services, and whether that's in our surgery or in our outreach programs as well. And we can talk to them about what might have gone wrong. A couple of weeks ago, I had a student that was in a car accident. He called in sick the day before, so I was able to go up to him and speak to him the next day saying, "Is everything okay? Do you need anything in Ballarat? Is there somewhere I need to send you?" or something like that. So it's really important to us that that's in place. The other thing that we do is we help students that are struggling. So we talk to them about this. We offer them support, we help them with the competencies that they might need, and we work together organising those patients for them as well.
At the end of the day, if I'm in the building still and I'm not at any meetings, I will go around at the end of the day and talk to the students and ask them, what have they learnt? Did they do anything different today? Have they, did they have an interesting patient? And I listen to their stories. I think that's really important, that they know that I'm interested in them at the end of the day, as well as at the start of the day. We're a bit like counsellors as well. In many cases, we've had some students who've had death of loved ones while they were with us, money concerns and or unwellness. So we make sure that we're there. I have an open door policy in my clinic anyway, so they might see me in the morning and say, "Can I see you at 5 minutes today?" And then we go through a few things. We do peer review sessions as a Grampians regional thing now that we hold in Ballarat, and we also have the students that can attend that as well. I'm happy to read any of their resumes, so they might ask me to read their resumes. We've done practice interviews on some of them last year, which they said, "Wow, that's amazing," so that was really good. And we talk about them about the cost of dentistry. When you leave, what it's going to cost you, what you actually need to know. That is actually your responsibility to know your instruments are sterilised, not the nurses, because you're the one that will be sued. So we go through all of that as well.
It's really important that we check in with our students. We actually are made aware by the clinical teachers when somebody's given a borderline or an unsatisfactory result. That allows us to build a relationship and let them know that they are accountable as well, that it's not being unnoticed, and we can support them in how that needs to improve. We measure their improvement by our DA feedback and our clinical teacher feedback. DAs are a great source of knowledge, and they generally know what's going on in the rooms and how people are doing it too. And we were talking before about audit results and the consistency of that, and then how we can create better outcomes for patients. We read all their compliments at staff meetings. We don't ignore the student compliments, and that they're valued as part of our team, and that we actually value their contribution to what they're doing for Ballarat Health Services as well.
And our staff often cheer and are really excited about their success stories.
And what this does is that we get engagements from our students. We have very little sick leave from our students. Everybody's really engaged when they turn up. They want to be part of it. They also volunteer for our other outreach programs as well, which is a great bonus. And then we know we're kicking goals. Please excuse the photo of Liam kicking the winning goal for the grand final last year. It's
I had to get that in, not just the dog today.
It's Jackie's son-in-law. We know we're kicking goals. The feedback that we get from clinics that have employed students that have been on program with us is that they are more rounded, that they are better equipped. Because we're not working students with students, these students know how to manage a surgery. They know how to manage a patient. They're not learning from other students, or they're not asking questions. They're actually having to come up with the answers themselves in conjunction with their clinical teachers, and other people aren't actually filling that in for them. And our students also tell us that they're more rounded, that no one's actually spoken to them about resumes or interviews or how to get a job or what's actually expected of them when they walk into a private practice, or how much money they're going to have to make in order to support that practice and their nurse and their receptionist and those sorts of things.
At that.
And that you know, we have about a 60% to 70% rate of students actually applying for jobs with us when they graduate. From anyone that's been on placement with us, they want to come back and work with us for all of these other reasons.
Mostly what I want to have at Ballarat Health Service is a motivated, happy work environment, and that is engaged, and that they're proud of each other within all areas, and they're interacting together. And to be honest, I think that we certainly kicked that goal many times, so thank you.
So kind, Gemma. So thank you, Jackie and Jodie. And now we're pleased to hear from Gemma, who's going to talk to us about merging to oral health services. So thanks very much, Gemma.
Thanks, Louise. I'd firstly like to acknowledge the traditional owners of the land on which we meet today, past and present elders, pay my respects. I'd like to acknowledge the sorrow of the stolen generation and the impact of colonisation. An ageing population, increasing consumer demand, and a changing regulatory environment has driven healthcare providers to sharpen their focus on value, cost effectiveness and efficiency, says head of the NAB Health Corporate Division, John McCarthy. This is not news to many and has already been our experience at CoHealth. Today I'll outline the process we took during the merge of our CoHealth and the oral health programs and our learnings. CoHealth was created on the 1st of May 2014 through the merge of Western Region Health Centre, Dudagala Community Health and North Yarra Community Health to better support people through service delivery, be a stronger voice in the health sector and to raise awareness of health issue and needs of our clients, and to provide leadership in this space. To commemorate the work involved in the merge and to say thank you to all those people, CoHealth commissioned a triptych, a three-piece piece of artwork by Nagab Francine Riches. This shows the relationship of people in harmony and the figures connected to the earth. The essentials for life, which are the rivers and the animals you can see there, and the fire, which provides warmth and cooking. The fire is also to gather families in for meetings and storytelling. The hands are the ancient signatures of the Kulin people and their land. Just as the river flow and merge, We have connection between once autonomous services, the communal reliance on traditions, nature and one another to maintain a healthy balance of life. A copy of one of the three images was given to all staff shortly after the merge. So who we are and where we work? Metropolitan Melbourne. We provide services to over 110,000 people annually from 40 sites across 14 local government areas. We see clients from 85 different background of languages, and 850 staff provide services including GP, dental, mental health, allied health services, health promotion, prevention, research policy and advocacy. So initially, the process of change at CoHealth involved communication, and certainly lots of it, because the merge was about the staff as well as the business of service delivery. We needed to celebrate the history and build excitement for the future and acknowledge people's uncertainty. Initial positions needed to be decided. Obviously, the board, the chief executive, Lynn Morgaine, was appointed in September 2014. Then the directors and their personal assistants, then the senior managers, and at that stage we had 2 senior managers for dental. Then we had functional groups established such as risk and compliance, health and wellbeing, clinical governance and diversity, etc. The CoHealth culture, as a new organisation, really need to be clearly articulated. Communicating this was led by our Chief Executive, Lynn Morgaine. The values we commit to are we care about the whole person and place the people at the centre of everything. Inquiry and innovation, respect, courage and social equity. The culture was embedded by early development of policies and actions such as the Code of Conduct, the Save Our Pharmacy campaign, diversity training, clients' rights and responsibilities. So this is what the Oral Health program was. We had a director, we had a senior manager, Oral Health West, which was myself, senior manager, Oral Health North, which is Anne Leonard, and then our staff. We had 4 sites, 78 Paisley Street and 2 Geelong Road, both in Footscray, 3 Matthews Avenue, Niddry, and 6 Gower Street at Kensington. 22 chairs and 80 plus staff, mixture of part-time and full-time. We maintained the status quo of having the 2 senior managers because we wanted stability. There was changing going on in the upper management, and we already had 2 well-seasoned managers. We needed normalcy for CoHealth, for clients and staff, and we needed to ensure our targets were met and services continued. We also had accreditation 1 month later, and we also had the new building starting at 78 Paisley Street. We wanted to ensure our staff felt supported and engaged through this process. So in the background, the oral health senior managers went to work looking at similarities and differences, the demographics across the areas, budgeting methods, past performance of the programs, nuances of each of the programs, FTA management, recalls, staffing levels, position descriptions, HR processes, staff training, all these sorts of things, working on identifying the best. Then we developed our change management plan for oral health and set priorities. During this time, we also had competing attention. Another accreditation in 2015 as CoHealth. The building was starting at 78 Paisley Street, and we were flat out spending NPA money. We had a further opportunity of change on the 20th of January in 2016. Anne farewelled us to take up a position with Charles Sturt University and the Holmes Glen BOH course in the undergraduate clinic. This gave us the opportunity to look for further efficiencies and a restructure. We needed to ensure quality was integral to and clearly defined in the new management structure, and any redirection of salary savings into service delivery. So now we have this structure. We still have our Director of Clinical Services, but the we have a much more inclusive management system. We believe in sharing wisdom, not one person holds the key to everything. We have a much broader group, and this team meets monthly. Enhance success for quality of clinical services, and we have clearly defined roles for the clinical leadership team. Challenging time for all of the staff who are involved in this, because all of these positions, except mine, people had to apply for and were interviewed. It took 5 months from the decision to go with this structure through the change management process and through HR processes to actually appointing the staff. And it required lots of trust and understanding from the staff in the clinic. So the surprises about this all were the staff, their willingness to rise to the challenge, the enthusiasm to work together between North and West, encouragement and understanding of all the staff, especially during the restructure for their line managers. Another surprise was just how much there was to do and the benefit in making the most of quick and easy yet meaningful changes. We reviewed and aligned all the salary rates. We aligned all the hours, increasing people from 7.6 to 8-hour days. We revised the FTA policy and implemented a no-blame culture for clients. We changed all our letters to plain English and easy-to-read letters for the clients, such as the recall, the FTA and the offer of care. And we changed the appointment books. Some of the staff were different colours across different sites, so they were just simple changes like that, yet they were quite meaningful. Some of the other challenges that we have 3 databases in titanium, one for Kensington, one for Niddrie and one for Footscray. Accreditation the first round, accreditation 12 months later. We had to decant out of 78 Paisley Street, and we also had to remodel 2 Geelong Road and install vans into that site. We had to build and open the new clinic at 78 Paisley Street, and then we had to move back out of Geelong Road, get rid of the vans and start up again in 78 Paisley Street. We had to redevelop the 6 Gower site reception. We had some issues with safety, and so it was redevelop and restructure that physically, that environment. And we've also centralised sterilisation processes for the whole of CoHealth. Oral Health look after those. And we think it's working because we're meeting our financial and DWAR targets. We've increased outreach services especially to the homeless people across North and West. We have a much decreased FTA rate. In one clinic, it's dropped by half. We've improved succession planning. We've increased our feedback, our number of feedback monthly, both compliments and complaints are encouraged because it's an opportunity to grow. Our complaints are all dealt with faster and obviously we can track the times of those. We have increased supervision for all staff. All staff have noted an increase in access to CPD. The high quality of clinicians' work is actually recognised. Our staff retention is high, and yes, we've had accreditation awarded in all of the times that we've been surveyed. So what have we got coming up? We've got the 12-month review for the oral health management team, our roles and responsibilities. There's 25 separate criteria which spells out across each of the positions who does what, and we're up to reviewing those. At time for our business plan review, we're establishing private practice, and we're also decommissioning the Kensington sterilisation room. Oh, that's too many. That one. Little saying, if there's no struggle, there's no progress. And there you'll see one of the old chairs flying out of 78 Paisley Street as it was knocked down. And here's our lovely new building. And I'm not sure if you can see this, but the river across the building flows across the whole lot of the outside of the building, and the river has lots of fish there as well, and it's a symbol of food and therefore sustenance and therefore well-being. The other thing is the gum leaves all across the building and that gum tree are a sign of welcome. So what better representation of community health? Thank you.
Thanks very much, Gemma. And now I welcome Stacey from Barwon Health. And Stacey is our last formal presentation, so I'm hoping you've got your questions ready for everyone at the end before morning tea, afternoon tea. Sorry, that's in case you thought you were getting away to your weekend. So Stacey's going to talk to us about the Type 2 diabetes screening program. Thanks.
Thank you. So I'm Stacey. I'm an oral health therapist and clinical team leader at CoHealth Area Health, and we work through Barwon Health. I'm not sure if anyone noticed my huge bump that I've got here. I'm very heavily pregnant with a very wiggly baby, so I apologise if I run out of breath or get a big sudden kick somewhere. I'm going to talk to you about the screening of diabetes that we've been doing at CoHealth Area Health at the moment. So obviously there's big associations between diabetes and oral health, and we're looking at exploring those links, but specifically periodontal health. So what we know is that if we can identify diabetes early, we can improve the outcomes for patients and hopefully decrease the complications associated with diabetes. By identifying patients with pre-diabetes, we can hopefully prevent the onset of type 2 diabetes. We know that poor blood glucose levels increases bacterial growth, so we are trying to assist patients to make some changes, lifestyle changes, that will hopefully reduce that poor blood glucose levels and hopefully prevent the progression of diabetes or pre-diabetes into full type 2 diabetes. So in Colac, at the CoHealth Area Health Community Dental Clinic, we service the areas between the Otway Ranges and the Great Ocean Road. We have a population roughly of 20,000, and approximately 7,000 of our adult residents are eligible for dental care with us at the clinic. So they are obviously healthcare card holders or pension concession card holders. Our patients travel up to 100 kilometres for treatment, so they're travelling quite a long way in some cases, and we're the highest disadvantaged area in the G21 region. The aim of our program has been to identify patients who may be high risk of having diabetes or may have pre-diabetes, and to try and reverse that for them. To try and potentially reverse the full onset of type 2 diabetes. So we're also looking at creating some pathways to diabetes educators and GPs throughout the area to assist these patients. And we're expecting to see some clear links between poor oral health, periodontal disease and diabetes. These are our Cert 4 dental assistants who are our oral health educators, and predominantly they have been working on the project for us. We've had a bit of a change to our model of care to incorporate this. So we have just incorporated this screening into our general treatment. So all patients, when they present, are offered a diabetes screening with their dental treatment. So there's no pressure, they don't have to agree, but if they don't consent, they continue on with their general treatment. However, if they do consent, we just incorporate this into their general treatment with an oral health education session with the Cert 4 DAs and their diabetes screening. So we have two parts to our diabetes screening. The first part is an OSDRISC questionnaire, which, for anyone who doesn't know, it's a series of personal questions that give a patient risk score for diabetes. So these can be age, sex, ethnicity, lifestyle factors such as food choices, exercise, the waist measurement. That gives us all an overall reading whether they are high, low or moderate risk for potentially having diabetes. So any of these patients who are identified as moderate or high risk are then offered a HbA1c score or HbA1c testing, which analyses blood glucose from a 3-month store. So it's just a simple finger prick blood test that we complete in the clinic. Any of these patients who present with a high or moderate blood sample are then referred on to the diabetes educator and onto the GP to confirm whether or not they do or don't have diabetes. and for maintenance or follow-up if they are pre-diabetic. So some challenges we have faced has been introducing the oral health educators into our model of care. They're a new addition. Before, we've just trained these Cert 4 DAs, we've only had Cert 3 DAs, so that's been a bit of a challenge just to try and work out their exact role and how they fit into the clinic. And just changing behaviours of patients coming in, what they're expecting, and also patient staff, how we intake patients, how we manage their appointments and that sort of thing. And also recording our data so that we can try and get some stats from this. So far we've screened almost 650 patients, or they've been approached to be screened. We've had 359 consent to the diabetes screening, more females than males, and more general patients than emergency patients have accepted the screening. We've had 90 decline, and 200 have been ineligible. Either they already have diabetes or they've been recently tested by the GP. From the OzRisk screening results, we've had 52% present as high risk, 45% of the females and 54% of males have been in that high risk category. And HbA1c, we've completed almost 250 tests, and we've found 17 patients so far who have been in the high-risk category that we have referred on to the oral health educator, the diabetes educator, and to the GP, and we're just waiting results to confirm whether or not they are or not diabetic. And it's been almost equal numbers of males and females so far. So we've seen that 2 out of 3 of our adult patients presenting to the dental clinic either have diabetes, they have been tested independently by their GP, or have a high-risk OzRisk score. So only 1/3 of our patients are not affected by diabetes at this stage. So we're hoping to reduce the impact for these patients, and hopefully those high-risk ones we can reduce or prevent them from fully progressing to type 2 diabetes. But we're waiting on some more definitive data and links to confirm the Perio Association. And we'd just like to thank the Collier Charitable Foundation, who has given us a grant and provided our HbA1c analyzers, and our dental staff and patients, obviously, for accepting our screening. Thanks.
Thank you very much, everyone. I think that's it's been terrific. And before we give everyone a final big thank you, I'd like to hear if anyone's got any questions I'd like to direct to any of our presenters. Thank you, Pam. In fact, you're so close, you can have that.
Great, thanks, Louise. First of all, congratulations to all the speakers. I found them very interesting and informative. I've probably got lots of different questions for different ones, but I won't hog the microphone. I guess with the last type 2 diabetes screening, how much time was taken out of your normal clinical time to undergo this process?
If you might straight for thanks, Phil.
So oral health educators have their own appointment book, so it's just a general appointment for them. So each test, I think the machine takes 3 minutes to analyse. Questionnaire obviously is just a couple of minutes as well, so no longer than a 15-minute appointment. But we generally put in an oral health education session as well with that, so oral health instruction with the educator, so maybe a 30-minute appointment.
Fabulous, thank you very much.
Thank you. Right, I'll come. We'll just divide the room there.
Thank you. Thanks to everybody for some really inspiring work, and congratulations to all of you. And this is not really a question, it was just a reflection from someone who delivers training in the tertiary environment to students. And I wanted to heartily thank the 2 clinics that talked about the way they hosted students and the support they provide for them, because I think, and reflecting on the second speaker with the mentoring program, that stuff's critically important to students, and I can tell you from the back end of that, the experiences that students have in community clinics is invaluable, and we certainly can't replicate that in our tertiary education sector. So I just wanted to say on behalf of all of us educators, thank you very much for the work you do with our students, because it's absolutely critical and a fantastic contribution to workforce sustainability in the future. So thanks, everybody.
Thanks very much. Are there any other questions? Excellent, I'll come down.
Yes, I too enjoyed the talks. I just want to direct a question to the first speaker, Keegan. I think it was. You had patients divide up those requiring general care and ones where there's risk to life and limb going to the emergency department. What sort of support or treatments did they get at the emergency department with regard to their dental problem?
So, in terms of the Frankston Mornington Peninsula catchment, we're based in a hospital setting with Frankston Hospital and have access to oral surgeons on call. So therefore it's important for us to include that information, and we have post-referral pathways and relationships with those services, and give an opportunity for GPs to refer direct to those services where it's probably more appropriate, rather than waiting until possibly the next day to access a general dental service, whether it's public or private. So it's about trying to streamline care and improve the appropriateness of the referral. Does that answer your question?
Thank you. Are there any other questions? I do have Pam in front of me, so she's my backup here. Pam, do you have any other questions?
I guess we've heard this morning about value-based care, and I guess I'm just interested to hear what people's thoughts are on that. And I suppose particularly with Gemma, where you've combined the two organs. Where's Gemma? Who's Gemma? It's probably very early stages in looking at value-centred care and what's needed, and new patient indicators from ICHOM, etc. But I'm wondering if you could just spend a couple of minutes on reflecting on what your thoughts were from this morning guest speakers on that particular topic.
Thanks for putting me on. It was actually quite interesting that my first interpretation of what we were going to hear is a different sort of value, and I was coming from value as in respect, dignity, culture, that sort of value. So it was interesting to hear that it's a value, dollar value, sort of how do you get the best outcome from that sort of point of view, which is about looking more about the respect, dignity and the culture of how you interact with your clients. And if you value the culture of client negotiation, then you should be, the other stuff will come, but because you start to look at the different sorts of outcomes, not for you and clinically what you think is a good outcome, but what the clients are going to want as outcomes. I think everyone's starting to tip their toe finger in this sort of space. I think we have no idea, and I suppose Nikki started to give us a bit of an idea of how much we don't know and we don't do about listening to our clients. A lot of us still think that oral health means every filling completed, every paraphy clean, but for a lot of clients that come, say, to Footscray, not being in pain today is good oral health. And so it's really about shifting our focus away from what we do. I I still think most of the time we're making patchwork quilts that don't last a long time in people's mouths. The great changes for oral health have been fluoridated water and fluoridated toothpaste. Fillings really haven't dramatically decreased caries experience. So it's about time we stopped thinking about how many fillings we do and start looking at what our clients actually want us to end up, or what their mouths want to end up. And most of the time it's probably got a lot to do with mouths, but there's their general health, which implies by our connections and links for oral health to help get them to where the sort of status of their health wants to be.
Thanks, Gemma. I appreciate that. Oh, excellent.
In regards to the telehealth speaker, with the rollout and getting this across the board a bit more, when you're talking about people not wanting to come to Melbourne, from an area that's about 4.5 hours away, so it is a bit hard for sort of regular checkups for something that's like oral med. How do you see the appointments and working that going forward so that oral med, you can see these rare patients a bit better?
I think probably what we've learned is this is changing how we'll deliver specialist care. So what we'll be looking at going forward is how can we support specialist care being delivered or being supported in the areas, and then how can we support you to extend to your fullest scope of practice, and how then if we have to bring them to Melbourne we can. So what we really learned is that we developed a community of learning when we did this, that the dentists themselves could do things and that they could actually contact us and ask us questions. So even now, Hun Lee, who's the oral surgeon, will get phone calls from the guys that she's done teledentistry for, or so will Nicole. And the other day, a dentist rang in and said, look, can you look at this intraoral, can you look at this picture? What do you think we should do with this client? So for us, it's actually developing a different way of delivering specialist care, and it is going to be more digital than telehealth itself. So when the dentist rang Nicole, we actually had to link into a telehealth session to see the photo, where if we get more digitally smart, those photos can come up quickly. So we have stepped back and we are looking at how we'll roll it out on purpose to see how is the best way to support you guys and for us to work together. So one of the things which wasn't in this presentation because we had 10 minutes, we did have a stakeholder workshop, and one of the things we said at the end is that referrals won't be rejected or accepted. Referrals are you guys saying we need help, we need some advice, and then how is the best way to do it? Is it a telehealth session? Is it a phone call? Or is it a session where you talk to the specialist and don't even have the patient there? So I think the next step is actually more exciting, and we'll work with you guys on how it happens. For the manager of specialist care, it's a challenge which is me, because we're going to move from, in a lot of cases, delivering care at the chair to actually supporting you to work with us to develop good specialist care. So it's value-based, I suppose, and with the patient. The difference of having the patient in the room was quite astounding with some of the work. Now, even the endodontic session, the person walked in and said to Dr. Koshi, I want an implant. And by the end of it, she wasn't getting an implant. She accepted the tooth could be pulled out and she wanted to marry him. Now, in 30 minutes, we did what could take 2 years for us to get done. So it's that sort of thing. So I suppose I'm saying watch this space. We're taking our time, but I think it's going to change how we all deliver care together. And that's how we see it.
Thanks, Diane. I was thinking you achieved in 30 minutes what takes The Bachelor many episodes. So good job. Are there any other questions at the moment? Yes, up the back, thank you.
This question is probably mostly directed to CoHealth's general manager. It's mostly an inquiry rather than a question. It's, they talked about the FTAs and the improvement of that they've done through the organisation and everything. And in one of their sites, there's been a significant decrease in the FDA rates. And I know FTAs attending to those things would be very tricky. Just if you can please explain as to how did you go about changing the policies on FTAs?
Thank you. We had a 25%, in the January 2016, it's 22.6% at FTA at Kensington. There was a perception of these naughty people didn't turn up. They would get a naughty letter, and it read like a naughty letter. And so most of the staff actually hadn't read the letter, so we read it out at a staff meeting, and they were all shocked to hear the language in the letter. So now the letter says, "We're sorry you missed an appointment, phone here." And it's as simple as that. It's not how much we value the oral health of your child or you or anything else. So that was one thing. We removed that nasty sort of... we also gave the clinician the booking of the appointment, not the client services or the reception staff. So any ongoing appointment is booked by the clinician. So there's like a verbal contract to attend the next appointment with the client. We also increased how far it was. We increased the bookings in the clinic. So previously, if you just didn't turn up for your appointment, you could get one a week later. Now you have to wait 3 weeks to get another appointment. So it's a disincentive to cancel your appointment. And we also had, when the client and the staff member has the discussion about making appointments, it's about when is the best time for you to come. And if you can't come, can you please phone us, because that's all right, happy to change an appointment. We also put in sit and wait clients, one for every dentist that works during the day. So some days at that clinic we might have 3 dentists. Another day we might only have 1 dentist and 3 OHTs at the clinic. So if there's a dentist, there's an emergency sit and wait booked on top of their full bookings. Oh, and it's last month it was 11%.
Thank you. I'm just going to do a final call for any questions. People, are they stretching or putting their hands up? It's like, oh yes, there we go, it's down. It's like going to an auction, isn't it? Okay. Well, I think that brings us to the end of the formal part. You will have the opportunity, the presentations will be available, and the contact details for people are on their slides, as you've seen. If, as a result of this, things occur to you when you're back in the clinic and you're having discussions, please send them through to us because they'll help us to inform what we do in the future for you. I'd ask you to just join with me one last time to thank all of our presenters today.